TopMedTalk.
This is TopMedTalk, the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. The EBPOM World Congress is taking place this year between the 7th and the 9th of July at the British Library in London. Check out ebpom.org now.
Hello, welcome to TopMedTalk. I'm Andy Cumpstey. It's a real pleasure today to be continuing TopMedTalk's new Perioperative Profile series. As many of you will know from our previous episodes, each month a new Perioperative Profile episode spotlights the professional and personal journeys of leading perioperative practitioners and researchers from around the world. We explore how they came into the field, what shaped their careers, some of their key challenges and successes, and also some of the things they perhaps wish they had done a bit differently, as well as how their work contributes to the evidence-based perioperative medicine that we all practice. Today, I'm really delighted that Professor Michelle Chu has kindly agreed to join us and share her periop profile with us. Michelle is currently Professor of Anesthesiology and Intensive Care at the Karolinska Institute in Sweden, and her research interests have focused around myocardial risk, both during surgery and critical illness, amongst other things, and she's led on several international guidelines in these areas. She's also an editor of the British Journal of Anaesthesia and Intensive Care Medicine. Michelle, thank you very much for giving up your time and sharing your perioperative profile here on TopMedTalk.
A great pleasure to be here with you, Andy. Thank you so much for this kind invitation.
Maybe you could start by telling our listeners a little bit about yourself and some of the roles that I've just mentioned and what you're doing at the moment.
I'm Malaysian born. I grew up in Australia, went to school in Australia, trained in Australia, and will probably be wondering why or how I ended up at the Karolinska Institute. The short story is that I met my husband while training in Australia, and he is Danish. I followed him to Denmark, and after obtaining my PhD in Denmark, I was invited to join Lund University Hospital in Sweden. So initially, I thought I would leave Australia for a year because I had started a training program there, but that 1 year has turned out to be 25.
Wow. I've got to ask then, so the training program you were on in Australia, whereabouts in Australia was that and what training program was it?
That was at Sydney University, and I started training in emergency medicine.
Right. How did you get into emergency medicine from medical school? And was medical school always on the cards? Did you always think you were going to be a doctor?
Yes, I did always think I was going to be a doctor. For some reason, nothing else ever popped into my mind. So this was a real dream come true. I trained at Adelaide University and then moved to Sydney after that. And while I was in Sydney, I was just so taken aback by the training program in emergency medicine, which was quite a young speciality then. So I started there. I was placed at PN Hospital, Western Sydney, at Westmead Hospital, and then I moved to Denmark after that.
How did you make that work?
I'm not sure if I really made it work. Things just happen and you just go with the flow. At the end of the day, I think somehow things have a funny way of working out.
Were you able to move straight into an emergency medicine job?
So having come from a tertiary country, so within the EU, there is the Bologna Agreement and agreements to accept qualifications from EU countries, although in terms of specialist qualifications, that's a different kettle of fish. But in terms of basic medical qualifications within the EU, there is a general agreement. But if you're coming from a country such as Australia, that would be deemed as a third level country. So I had to repeat internship in Denmark and partially in Sweden as well. So I've done internship 3 times.
And I'm guessing you could already speak Danish and Swedish when you made that move, or did you have to brush up on that at the same time?
Well, I had to learn it from scratch.
Gosh. So you started with another internship in Denmark?
Correct.
And then where did anesthesia and intensive care medicine start to rear their heads?
Well, that's an interesting story as well, because we take it for granted that emergency medicine has always been there. There's so many TV programs and it occupies quite a lot of social media and public awareness, whereas anesthesia and intensive care don't. I guess COVID has really brought intensive care to the forefront, but before that, nobody really knew what an anesthetist or intensivist did. So when I went to Denmark, nobody knew what emergency medicine was. Nobody had heard of it. And I was told that the closest thing to emergency medicine was anesthesia. So this is how I started my career in Scandinavia, because there was nothing else available. So it was just a serendipitous situation, I guess you would say.
And for many of our listeners from around the world listening to this now, can you give them a sort of a quick summary of what training in Denmark in anaesthesia looks like, how long it is, how it sort of works, what the rotations might consist of?
Sure. So it's quite different from what it is in Australia. So in Denmark, at least at the time, and this was, this is 20 years ago, you'd apply for an introductory position, and that was I think it's 12 or 18 months. So you would do some very basic training in anesthesia. And when you're finished with that, then you would apply for your main training block. And I think that was 3 or 4 years. So I did my introductory block in Denmark before being invited to Lund University. I was very lucky to get a position that offered me research as well as a clinical job at the same time. So what I did in Denmark was first to complete my PhD. That was a 3-year program, and then I started working clinically after that.
And that PhD was not part of the normal training program. You were doing that in time out or in your own time? Or
Yes.
So where did the interest for that come from? Why did you seek out research opportunities rather than just straight clinical programs?
Well, I was always interested in research. I thought it was an incredibly exciting opportunity. I did some voluntary work in Denmark. I knew that I couldn't work clinically because, I didn't have the language skills, especially in an acute care type of speciality such as anesthesia and intensive care. It really requires a lot of communication skills. So it's not just words, it's understanding the nuances and the culture. So I was studying at language school and volunteering at the lab at Aarhus University in Denmark. And that's how I got in touch with my supervisors, who then offered me a PhD program. And I thought it was a great opportunity. So it was in haemodynamics. It was looking at novel ways of measuring cardiac output with ultrasound in animal models, but it was really for pediatric cardiac output measurement using echocardiography.
And it sounds like that's really set you on that road ever since. And now look at where it's led to. But I guess it's interesting for people to think about that at the time. And it sounds like it was partly through something you found interesting, but also partly because that's what the opportunity was when it came up. Is that fair, or was it?
Absolutely. So I guess for our listeners, I guess one of the main messages of my life, I guess, is never miss an opportunity. You never know where you're going to end up.
Very good advice. So after that PhD, then you went back into clinical training and finished the anesthesia residency?
So that's right. So I finished my introductory residency in Denmark because that's how it's set up, is an introductory year, 12 to 18 months, and then you do your main block. So after that introductory period, I joined Lund University in Sweden, partly because I applied for a position and I was very lucky to be awarded a grant as well that would allow me to both train clinically and do research at the same time. My mentor at that time, Professor Elsa Tønnesen, who's possibly one of the most wonderful people I've ever met. She was a great mentor. She was a great teacher, great researcher. She had trained in Malmö, which is affiliated to Lund University, and highly recommended that I left Denmark at least for a few years to obtain my clinical as well as research training and then to come back to Denmark.
And did you come back to Denmark?
No, I did not.
That's, again, as you say, you never know where things are going to take you. But so you made the move over to Sweden and then...
Well, then another opportunity came up. That opportunity was to keep developing my research program. So what I did then was I built on the experience that I gained in Denmark at the experimental lab. I was able to start my own group, and we did a series of experimental work in haemodynamics, both in septic and haemorrhagic shock, in looking at myocardial changes and what happens in septic shock. So that was another opportunity that was too good to pass up.
And what's your split now in terms of clinical work versus research work versus, we'll get into the editing in a second, but all the other things that you do as well as those two things?
On the official level, I'm supposed to be doing about 50% clinical loading and 50% of everything else. But I think for most of us working in academic positions, the 50% is probably not really 50%. That's okay. That's what we choose to do.
Is that sort of 50-50 split something that you've kind of managed to achieve going through your residency, through your training? It sounds like you managed to find routes where you could get positions that offered you opportunities in both all the way through. Or did that split sort of have to wax and wane at different times depending on different parts of the program?
Yeah, absolutely, Andy. And, even if there is a 50-50 split, we do know that patient care comes first. So despite the fact that, at least in Scandinavia, you're usually guaranteed this 50% split, sometimes that's just not the case. And I think you need to be able to be flexible enough to understand that needs do change over time and to adapt to those changes.
But so you moved across before all this happened with your husband then. How did family life fit into this? Because you were trying to combine learning a new language in a new country, and then a new research program in a new country, and then a new clinical training program in a new country. That's a huge set of challenges in itself without trying to worry about everything going on at home. But it sounds like you've managed to make it all work somehow.
I've got an incredibly understanding and flexible family. They all work very hard. I've got a son we have a son who's 14, and he's just uncomplicated, just such a joy to have. There's never been any problem. He was a preemie. We were in hospital for many, many weeks because he was so premature. But, even during that time, we managed to run the USOS study. So, things do work out, and I don't think I'm really different to anyone. I think it's just a matter of prioritizing your time. I guess it's just about your basic values. What are the things that are most important to you at the moment, and what are the things that can wait? I don't really believe in this life balance. I guess balance means different things to different people, and this is one of the reasons why I try not to use that word, because life is about juggling a lot of things at the same time. It's about trying to figure out what's important to you, your family, and those values will differ from from person to person and from time to time. So, and it's not easy, Andy, I don't want to harp on the gender issue, but I do believe that despite all the infrastructure that is available in Scandinavia for women to work and to have a family life and to have a reasonable, balanced, if you like, life, I still think that there are significant challenges for women in academia. At the end of the day, it's, you come home and you figure out, do you need to get dinner for the kids, or do you need to work on that paper? And that's what it comes down to.
We've covered this in other TopMedTalk episodes that you'll have heard before, and Kate Leslie, who we both know very well, is a very strong advocate of this as well, and quite rightly. But I'm often amazed at some of those episodes when I sit there and hear things that people I'm speaking to have had to go through or enjoy to get to, what other people might not have realised gone on in the past. But they've all talked about these challenges, not just gender related, sometimes other issues, but it's often not those things that people see when they look at people's success stories afterwards. How do the people that listen to this at home, when they look at yourself or Kate or any of these other very successful women that we've spoken to, how can they relate to that, and how can they help get themselves through those more challenging periods?
Kate is definitely one of my biggest role models. I look at her and I'm completely in awe, and I just wonder how she does it all. But everybody has ups and downs, and I think there was a Bluey episode where where the mom said, you have a bit of cry, and then you get up and you pick yourself up and you get on with it. And I'm not saying that you shouldn't feel sorry for yourself once in a while. I feel quite sorry for myself every once in a while. But then you get up and you dust yourself off and you get on with it, because wallowing in your own sorrows certainly isn't going to get things better. And at the end of the day, we do have opportunities, and not using those opportunities is really just, it's a great loss.
Yeah, well said. Let's move away from that then to something outside of work, perhaps. But so what sort of things are you interested in outside of work? Or what do you do with your son and your husband?
Okay, here we go with the priorities again, because my 14-year-old does a lot of sports. So I'm not a sporty person at all, but I've kind of been forced along with the whole momentum of the parents and sports scene to be drawn along with it. So he mountain bikes a lot, which scares the hell out of me. So I try not to watch too much of that. So luckily my husband does most of that, but he used to play basketball, and there was a lot of basketball training and making coffees and selling cakes and all those sorts of things. So all that needs to fit in as well. But, I can tell you, I bring my computer everywhere with me. So that's definitely possible. And then it's also a really good way to, being forced to do things like taking your kids to sports is a really good way to force yourself to stop overthinking things.
Can I ask you mentioned it a bit earlier, but ask you more about the editing roles. And obviously, I mentioned a couple in introductions. You're an editor for the British Journal of Anaesthesia and also for intensive care medicine.
So being an editor is a gift. You get this enormous insight into research all over the world before anybody else does. And the way I got into it was actually via the European Journal of Anaesthesia. Probably about 15 years ago, I was asked to join the team as associate editor, and then I became deputy editor-in-chief, and that just gave me so much insight into the editorial world. And then I've stepped down from that role. I'm still an associate editor for the EJA, and I joined the BJA team. And then I was also editor for critical care, which I've stepped down from now as well because it's just too much editorial work. The way I see things is that it's give and take. There is an enormous amount of information to have to sift through, but it's also a huge privilege to be privy to that information that most people are not exposed to. So I think you need to make that decision for yourself, whether or not this is something that you want to do and whether or not you feel that you would personally gain and grow from it.
So that leads nice onto my second question, and that's what does it actually involve? Because I think many people probably don't really see that side of it until they're doing it, but they might only interact with an editor maybe with one or two emails, either a happy acceptance letter their paper's been accepted, or perhaps unfortunately a bit more likely, unfortunately there isn't space for that to be accepted all the time, and a rejection letter or some recommendation of how to make some changes. But they don't see what goes on behind that process of where that decision's come from or what the editor's role in that actually is. Talk our listeners through what you would do as an editor from when something lands in your inbox to sending one of those two letters out a little bit later.
So Andy, you know a lot about this yourself. You were one of our STI editorial fellows, and there is a lot of work that goes into that one editorial letter, be it an acceptance letter or a rejection letter or a revised letter. So when the editor-in-chief assigns me a paper, I read the abstract first of all, and then I make a very quick decision. Is this something that could possibly contribute with novel information, or could it be confirmatory information on an important clinical question? There is this flurry of searches in PubMed to try and, get very quickly up to date in that area. And then, it usually entails reading the paper 2 or 3 times before you need to decide whether or not to send it out for peer review. And the peer review process in itself is sometimes quite challenging. It's more and more difficult to find reviewers that will do this out of their own goodwill because it does take time and it's non-remunerated. Not everybody wants to do this because it's a significant burden on your daily work. And then once all those reviews have come back, you need to somehow synthesize those comments and those concerns and then write a sensible letter back to this. Now, sometimes the manuscript may be very well written, but doesn't contribute much, in which case I always feel a little bit bad when I have to reject a paper that has been really well written, but really doesn't contribute anything novel. And on the other hand, there are papers that are horrifically written, but have such important novel data that really you need to put in a lot of effort as an editor to get the paper up to scratch. So a lot of work goes into publication of a manuscript that it's not visible to most readers.
And how much of that do you take on individually, and how much of that is handled by the administrative team of the journal, the editorial office of the journal, whatever? What sort of jobs does each side of that relationship to take on? Because you do have to work very closely together, don't you, to make it successful?
Yes, absolutely. And I think the BJA and most, most high-ranking journals have a very polished system. So there are a set of logistical checks that every manuscript has to go through. And then the paper gets sent out to us. There is always a plagiarism check as well. And then you go ahead with your editorial work. And when the paper has been accepted, it goes back to the editorial office for processing with your edits, of course. And then I don't know if they call it typesetters anymore because we don't really have typesetters anymore, but the person who does that kind of editorial job has this they do amazing things to the manuscript. They tidy up and make it look really pretty before it's actually published online. And after it's published online, it's published in its paper version. So all those sorts of things take an enormous amount of time, and the editorial office, I don't think we could live without them, maybe.
From that editing work and the editing role, we should talk about the guideline work that you've been involved with over the years as well. Can you maybe tell some of our listeners some of the guidelines you've been involved in, the different roles you've had during your career?
So I've been involved in a number of guidelines, both in intensive care and perioperative medicine. So the last guidelines that we published were the ESICM guidelines on shock and hemodynamic management. And that was a huge work that took almost 3 years to do. So the first step with writing guidelines or formulating guidelines is to determine whether or not it's actually needed. If there is a need, then you need to figure out what are the most important research or clinical questions that you want answered. Is it possible to answer them? And then you need to gather your experts, and they need to be gathered in a way that includes a diverse, both number and type of experts, that includes all stakeholders. And I think not every guideline does that, but I know that this is becoming more and more the standard. And then usually if there are very big guidelines, you divide the research question into different groups, and then each group will go and do a literature search, and then you go through the literature in a systematic way, and then you try and answer those research questions. Now, not everybody agrees on everything. Getting consensus is difficult, and it should be difficult because medicine and physiology is not straightforward. And I think guidelines help us consolidate the information that is there. It highlights agreements and disagreements and areas of further research. So while many readers and perhaps some of our listeners may think that, well, guidelines don't really answer the question for this particular patient in front of me right now, I think they do help by consolidating information for a group of patients given the clinical data that's available.
How did you make that initial jump into guideline writing or working on guidelines?
So I was involved with the Scandinavian Society of Anesthesia and Intensive Care Clinical Practice Guidelines Group. This society doesn't issue very many guidelines simply because it's a smallish society and there are a lot of guidelines available. And one of the important roles of the Scandinavian Society is to consolidate everything else that is around. So we're not talking about reinventing the wheel. We know that there are a lot of very smart and very disciplined people out there, and we try to adapt some of those guidelines to the Scandinavian situation. And this is the other thing I also want to say about guidelines. Guidelines are guidelines. You need to be able to adapt them locally. And then I was involved with the European Society of Anaesthesiology and Intensive Care in the guidelines group as well, and also learned a great deal from that. I was involved in the Perioperative Evaluation Guidelines many years ago under the leadership of Stefan de Hert, and then later worked on the Focus Biomarker Guidelines.
You've touched on this a little bit already as we've gone through these different topics, but I want to ask it directly because it comes up as a theme again and again and again when I have spoken on these Perioperative Profile episodes. A lot of the same words come out and people say, I was lucky to do this, or I was lucky to do that, or there's an opportunity here. And then they talk about mentors and sponsors and role models. And again, you've mentioned a few of your mentors and role models already in passing, but are there any people that have really shaped either your decision making about to take this opportunity or not take that opportunity, or really helped you progress through at key points in your journey?
Oh, absolutely, Andy. And I can't tell you how lucky I've been. My late grandmother, she passed away probably about 10, 12, 14 years ago. She grew up in Malaysia post World War One, and under the Japanese occupation of World War II, her family suffered a great deal because her husband was the mayor of the town who was well educated. My grandmother was one of very few women who were educated at that time, and they worked for the Sultan of that state. So he was interred in a Japanese POW camp and died of his injuries soon after the war. And my grandmother was a fiery woman who never missed an opportunity, coming from a well-to-do family to a family that, didn't have very much after the war. She raised 6 children on her own. So when I feel sorry for myself, I think back to that time. She never spoke of her hardship. So, and I'm not advocating that, you bottle up hardship, but I think it's also about seeing life as opportunities and what you can do with it rather than feeling sorry for yourself. You just need to dust yourself off and get back on that horse. And later, when I was in Denmark, I was very lucky to be mentored by Professor Else Tønnesen, who's a retired professor of anesthesia in Aarhus in Denmark. She taught me the value of gathering a good team around you. Now, not everybody is good at everything, but you can harness the goodness in every single person and their opportunities in every single person so that you can build collectively a good team together. So she taught me that. Tony McLean from Sydney taught me the value of humanity. He taught me the value of how to do a good echocardiographic examination and how not to be too sure about yourself. He also taught me how to be just a decent, gentle human being. Rupert Pierce, a great friend and possibly the one sponsor I've had, and there is a difference between a mentor and a sponsor. Rupert really opened a lot of doors for me, and he was a constant reminder to me of, just get up, dust yourself off, and keep going. Rupert opened the world of perioperative medicine to me as well. So I think many of those people that I've met throughout my career, throughout my life, I've just has been out of, pure luck, but also opportunity and the realization that you can learn from anyone, really.
Fantastic answer, thank you. And just to follow on from that question then, for anybody listening at home who's thinking about either trying to add research into their clinical sphere or get into peer reviewing or editing, or maybe it's guideline work or whatever their ambition of interest might be, how can they go about finding those people that can help them on the way or give them that advice or that supervision, steerage, whatever the phrase is?
So there are lots of opportunities. The BJA has editorial fellowships. This is also offered by many other journals. Don't miss an opportunity to be a peer reviewer, even if it takes work. This is where you get started. I did hundreds of peer reviews before I was asked to be an associate editor of the EJA. The most important thing that I've learned is that you don't get anywhere if you don't put in the work yourself. There is no way around it. You still got to put in the elbow grease.
Anything else that we've not covered that you think we should discuss?
I think given the state of the world today, I think we all have a role to play. Science is a beacon of hope. Clinical medicine is the way we execute that hope. I think we should never lose sight of why we're put here. At the end of the day, we're all physicians and we're here for our patients, not for ourselves. It's really easy to lose sight of that. And I think sometimes we all need to stop and take a deep breath and just remember why we're all here in the first place.
Yes, very strong message, very strong words. And I think on that note, that's a perfect note to say thank you very much, Michelle, for joining us here on TopMedTalk, for sharing your perioperative profile, sharing those amazing words of wisdom and advice for everyone that might be listening. And thank you for all you do for all the different journals, guidelines, and all the things behind the scenes that we don't see.
Thanks very much, Andy. Real pleasure to spend this time with you. Thank you so very much for having me.
As always, you can hear this episode and other previous perioperative profiles and other episodes on TopMedTalk's website. You'll find us on whatever your podcaster of choice is. We're also on social media. If you do find us on social media or YouTube, please do hit like, hit subscribe. It really helps us at this end. And of course, a huge thank you to our sponsors for keeping us free and open access around the world. And this year, that's BD Advanced Patient Care, Advanced Patient Monitoring, and GE Healthcare. Thank you.
TopMedTalk.
TopMedTalk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. Join clinicians from around the world at EBPOM World Congress 2026 between the 7th and the 9th of July at the British Library in London. 3 days of evidence-based perioperative medicine, global insights and expert debate, featuring speakers including Michael Marmot and Ken Rockwood. Go now to ebpom.org. That's ebpom.org.